Hello everyone, my name is Arjuna Panapalam. I'm a transfusion medicine physician with Shared Health and a hematologist with Cancer Care Manitoba with the Department of Pathology at the University of Manitoba. Today we'll be talking about the Transfusion Stewardship program here in Manitoba and specifically on restrictive transfusion practice and also talking a little bit about transfusion associated risks pertinent to the current project. At the end of this session, you'll be able to appreciate the contemporary evidence for restrictive transfusion practice, particularly for red blood cells, and identify potential harms with the liberal transfusion strategy and its associated transfusion reactions, and finally become familiar with Shared Health clinical practice change, particularly for red blood cells for inpatients. Now, one of the documents created by the collaborative group, which includes Choosing Wisely Manitoba, Best Blood Manitoba, and Shared Health, includes a poster that outlines the different algorithmic steps for transfusion practice, and we'll use this as a template as we go through the presentation. Now, typically, when red blood cells are transfused for patients, the primary objective is to improve the oxygen carrying capacity to improve in patients who are anemic. Sometimes red cells are also transfused to improve hemostasis, particularly in patients with low platelet counts. And in patients presenting with massive hemorrhage and shock, it's used as a resuscitative volume expander, particularly in hemorrhagic shock. Outside of this, transfusion of red cells can also cause unwanted transfusion reactions, including transmissible infections, allergic proteins that can cause allergic reactions and sometimes anaphylaxis, and other proteins, including cytokines and antibodies, which can cause unnecessary reactions and morbidity to the patient. And so it's important to keep in mind that as patients are transfused to improve the oxygen carrying capacity, there are also other adverse events that can happen to patients. Now, one of the major points with this poster that I'd like to highlight is that a restrictive transfusion strategy of 1 unit at a time is indicated for patients who are not actively bleeding and who are otherwise hemodynamically stable. So primarily for patients who are admitted to hospital who have anemia for other reasons unrelated to bleeding, this type of restrictive strategy would be appropriate. For patients who are presenting with active clinical bleeding and are hypotensive and are in shock, it would be inappropriate to use such a restrictive transfusion practice, and transfusions in that setting is often dictated by clinical judgment at the bedside. Now, focusing on the green bar, the current recommendation by this group and most clinical evidence is that single unit of red cells should be transfused if the hemoglobin is 70 grams per liter or less. And 70 grams per liter is much lower than the normal range for female, which is 120 to 160 grams per liter, and for male it's 140 to 180 grams per liter. And so why have we established this as the threshold? And in the subsequent slides I'll be talking about the clinical evidence for that. Prior to the 1990s, the established rule for transfusion was a 10-30 rule, which meant that if the hemoglobin was less than 100 grams per liter or less than a hematocrit of 30, transfusion was deemed appropriate. But this was not based on any clear controlled clinical trials, and it was the established norm at that time. This is data showing the tolerance of anemia for healthy individuals, and I've put this slide in here primarily to illustrate that even though the hemoglobin can drop significantly, we have built-in mechanisms to compensate for anemia. And so as you move on the graph from the right to left in the 4 quadrants, patients are sequentially being made anemic by phlebotomy and replaced with normal saline. And you can see as the hemoglobin drops in these healthy volunteers from a normal of 140 all the way down to 50, various physiological parameters change, and these are normal adaptive responses to anemia. On the top left, you'll see an increase in the heart rate as the patients become more anemic. And on the bottom left, you'll see an improvement in the cardiac index as patients become more anemic. And these are all common responses to bleeding or anemic acute anemia. On the top right, you'll see the oxygen consumption curve, which does not change as patients become anemic, and neither does the change in the lactate. And this is primarily because the body is designed to increase oxygen extraction, and so as patients become quite anemic, they can maintain good tissue oxygenation without lactic acidosis. Now, on the left graph here shows oxygen delivery, and on the right, oxygen consumption. Oxygen delivery is dependent on the hemoglobin concentration, and so if the hemoglobin decreases by baseline from 100 to 75 to 25%, you will see a concomitant decrease in oxygen delivery, and this is quite conserved across different mammalian species. But despite the drop in the oxygen delivery, oxygen consumption is maintained up until a critical anemia of almost 25% of normal. And this is primarily because of adaptive responses in oxygen extraction. This is being illustrated primarily to show you at which point on the oxygen consumption curve would red cells be useful clinically. And so ideally, you would want to transfuse patients when the oxygen consumption is on the downward trend, so on the red part of the slope, because that's where you'll have the best benefit in improving oxygen delivery without the harm associated with transfusion-associated risks. If you transfuse patients on the black part of the curve, the flatter part of the curve, you're not improving oxygen consumption significantly, but you are exposing patients to unnecessary transfusion reactions. And so in the subsequent few slides, we'll review some of the clinical evidence for restrictive transfusion threshold, now that we've seen that patients can and healthy volunteers can tolerate significant anemia. Now, this is a landmark study done in critical care patients published in the late 90s. Part of the clinical trial was designed to identify if there was any harm in waiting for patients to drop to a hemoglobin less than 70, and that was a restrictive transfusion strategy. And this was compared with the liberal transfusion strategy, where patients were given 1 unit of red cell if the hemoglobin dropped to less than 90. This is the first large clinical trial looking at a restrictive versus liberal transfusion strategy. And this graph outlines the survival curves of these patients for the first 30 days. And what they showed quite nicely was there was no difference in mortality outcomes when patients were randomized either to the liberal or the restrictive transfusion strategy. And so what they showed quite nicely was that it was quite safe to wait till the hemoglobin was less than 70, and it was equivalent to waiting till the hemoglobin was less than 90. And one of the benefits of a restrictive strategy is that much fewer patients in this group got transfused by almost 30%. Now, this is another survival curve from a different clinical trial. This was published in 2013. And the population examined here, unlike the previous one, which was in ICU patients, in this group, it was patients presenting with stable GI bleed. And what they showed was that a randomized protocol for a restrictive strategy, which was transfusing when the hemoglobin was less than 70, was in fact superior to a liberal strategy where patients were transfused when the hemoglobin was less than 90. Superior in the sense that there was less morbidity and mortality related to a restrictive strategy. This was one of the first clinical trials that actually showed a restrictive strategy had a superior mortality outcome. Now, this is a more contemporary trial from 2014. Once again, I'm just showing you data from different population groups. These are patients who were admitted to intensive care units with the diagnosis of sepsis. And in this group, they were randomized to a lower hemoglobin threshold of less than 70 or a higher hemoglobin threshold of less than 90. So once again, a very common restrictive versus liberal transfusion threshold. And what they showed here was there was essentially no difference in mortality curves over the 90 days of the study period, meaning that it was quite safe to wait till the hemoglobin was less than 70, even in patients admitted who are quite sick to ICU with septic shock. Now, this is a summary plot of the clinical evidence in which patients have been randomized either to a restrictive or a liberal strategy over the years. And as you can see, the trials run from the late 90s onwards to as early as 2015. And there have been close to about 5,000 patients randomized to each of the arms. And as you can see, the summary plot shows no difference in mortality outcomes for these patients, meaning that in almost all groups that have been studied, there appears to be no benefit in transfusing when the hemoglobin is much higher than 70. Now, the summary of the evidence then suggests that the appropriate benchmark for transfusion of red cells is 70, and this has been the established benchmark in current clinical practice. Once again, just to reiterate that this would be appropriate only in patients who are not actively bleeding and otherwise in shock. If the hemoglobin falls between 71 to 80 grams per liter, then it becomes difficult to judge if patients should be transfused or not, and it would almost often be dependent on if they have active symptoms. And if the clinician deems it necessary that a patient ought to be transfused because they have active symptoms, then a transfusion would be appropriate. We recommend giving 1 unit and reassessing the hemoglobin for subsequent units. We will be doing retrospective audits of transfusions within this threshold of 71 to 80 to see if they were indeed appropriate, and over time we're hoping to identify population groups that may benefit from this and also provide an opportunity for education of physicians. Now, the other intervention with this red cell utilization program is trying to encourage the transfusion of 1 unit at a time versus 2 units. And historically, when patients have been anemic, 2 units was the standard dose of transfusion of red cells. But over time, many clinical trials have been designed with protocols that only transfuse 1 unit at a time with hemoglobin repeated after every single unit. And so we are advocating that 1 unit at a time is safe and should be the standard of care. The transfusion of 1 unit at a time with reassessment frequently with hemoglobin and symptoms reassessment will minimize the risk of unnecessary transfusions while maximizing the benefit of improving oxygen carrying capacity. Now, some of the feedback we have received in the past has been how soon can the hemoglobin be measured after transfusion, and many varying opinions have been put forth in the past as to when hemoglobin should be checked after a transfusion, whether it can be done after 2 hours or should someone wait for at least 12 hours. And so this has been answered quite nicely in a prospective controlled trial where they gave patients 2 units of blood and measured their hemoglobin at the 15-minute mark, 1 hour, 2 hour, and 24-hour mark to see at which point the hemoglobin measurement best reflects the transfused product. And they've shown quite nicely that a CBC measured 15 minutes after the transfusion is equivalent to checking a CBC at the 1, 2 hour, or 24-hour mark. And so we recommend that after a single unit transfusion, hemoglobin can be checked within 15 minutes. And if that still shows a level that requires additional units, then we recommend giving an additional unit and rechecking the hemoglobin as needed with every subsequent unit. Now, as we move to the red bar, so in this it states that if the hemoglobin is 81 grams per liter or greater, stop and do not transfuse. And that's primarily because the clinical evidence to date does not justify routine transfusion at this threshold. Of course, there are probably certain patients with significant comorbidities that may benefit from transfusions at this threshold, but in order for the blood bank to release the particular unit, a transfusion medicine physician on call consultation would be necessary to receive product for these patients. We're establishing this as a threshold primarily because the clinical evidence does not support transfusion at this level, and patients are often exposed to unnecessary transfusions, and we're hoping to minimize some of those unnecessary risks, which are detailed in the gray box at the bottom, which shows the contemporary estimate of risks of transfusion, which include transfusion-associated circulatory overload, which is in 1 in about 700 units issued, and other transfusion-related risks, including trolley, hemolytic transfusion reactions, septic reactions, and death. And the risk estimates have been detailed in the gray box. Now, outside of those risks, there are also other transfusion-associated hazards, and these can be split into both immune-mediated and non-immune-mediated. And in the red, I have identified the more common reactions, including hemolytic, febrile reactions, trolley, alloimmunization, and in the non-immune, the more common being septic and transfusion-associated circulatory overload. There are other reactions which tend to be much rarer, but can be meaningful, which includes things like transfusion-associated graft versus host disease, which can be mitigated with irradiation. And in patients who are chronically transfused, they can develop iron overload and significant morbidity related to that. Now, one of the difficulties with identifying transfusion reactions is that certain signs and symptoms can be found in a variety of different reactions. And so, for example, in a patient presenting with fever with a transfused red cell, it could be related to a febrile non-hemolytic reaction. It could be related to acute hemolysis, bacterial contamination, or even something as severe as transfusion-related acute lung injury. Whereas for patients presenting with, say, dyspnea, it could be related to anaphylaxis, acute lung injury, or transfusion-associated circulatory overload, which means that symptoms can sometimes present in severe reactions and sometimes in mild reactions, and so therefore we encourage high vigilance even in someone presenting with fever that's mild to ensure that none of these evolve over time into serious reactions. And part of a restrictive transfusion strategy is on the whole to try and expose patients to less blood than they need, and by proxy we're hoping to decrease the number of transfusion reactions that they would otherwise have. Now, in terms of frequency of these transfusion reactions, this chart just identifies how common these are compared to other contemporary transfusion risks. And so, for example, the risk of transmissible infections like HIV and hepatitis C are quite minimal these days compared to more severe reactions that can cause morbidity, which are transfusion-associated circulatory overload, which can occur in as frequent as 1 in 100 transfusions to 1 in 700. Now, this is data from the Serious Hazards of Transfusion annual report from the United Kingdom Blood Service, and they've identified the common culprits that cause severe morbidity and deaths associated with transfusions. And in this graph, they've shown the different causes of transfusion-associated deaths from 2010 to 2016, of which 115 different deaths were reported to the blood service. And of these, pulmonary complications are quite common, and of the pulmonary complications, transfusion-associated circulatory overload is also quite common. And in 2016, they reported 26 cases of patients who had significant morbidity and actually mortality related to transfusions. And of these, transfusion-associated circulatory overload was a significant one. And we're hoping that with a restrictive transfusion practice, it would lead to a reduction in unnecessary overtransfusion in patients. One key point that should be made is that another cause of serious harm to patients is the delays in getting blood to patients. And as we're developing this project, and we identify that delays in getting blood to the patient can become problematic, and that's why we do have transfusion medicine physicians on call to deal with immediate questions related to transfusion in patients and delays in getting blood to them. So to reiterate, the benefits of a restrictive strategy is that you get less exposure to blood products to patients, and by proxy less reactions and less morbidity. And the clinical trials have shown that a restrictive strategy of waiting till the hemoglobin is less than 70 is non-inferior to a much more liberal strategy. And there doesn't appear to be a signal of harm with being restrictive in clinical practice. One of the added benefits of sticking to a restrictive practice in patients who are not actively bleeding is that it also improves the inventory of blood products for the local blood banks, and there are other further higher order economic benefits to the system as well. Now, the major randomized trials that I have presented earlier, and they have all shown that a restrictive strategy leads to about a 30 to 40% reduction in patients being transfused. And so we're hoping that with the implementation of a restrictive strategy provincial-wide, we'll also see, in addition to clinical benefit to patients, a reduction in the amount of blood being transfused as well. This is data showing the a per capita transfusion rate. So this is the amount of transfusions per 1,000 population. And you can see, although Canada is not on here, comparatively speaking, the US, which is similar, has a rate of 34.5 units per 1,000 population. And in Canada, we've seen an overall reduction in the RBC units being transfused per 1,000 population over the years, starting in 2009 at 32.3, and more contemporary numbers are much lower at 25.3. Now, if we compare different provinces, Manitoba presently is sitting in the sort of middle of the graph, and you can see each of the bars represent different year time periods. From 2016 up until 2019-2020 year. And we're seeing a reduction in transfusion rates, but clearly some provinces have much lower rates and others have higher rates. And so we're hoping to align ourselves with a restrictive strategy which has been implemented in other provinces, such as in Saskatchewan. Therefore, to summarize, this poster identifies all the key points. The first point, intervention we're hoping to implement is just one, meaning to transfuse 1 unit instead of the commonly prescribed 2 units of transfusions. And we're hoping that patients receive a single unit and are reassessed for clinical benefit. And if a second unit is required, a repeat hemoglobin is being done. And the different colored bars show the different thresholds at which patients should or should not be transfused. And so if the hemoglobin is less than 70, then transfusion is appropriate. If the hemoglobin is between 71 and 80, it would be appropriate if they're symptomatic. And if it's 81 grams per liter or greater, then transfusion is often not necessary, but in certain cases they can be approved by the on-call physician. And just a reminder that transfusion medicine physician is on call 24/7, and they can be reached through your hospital paging, or if you don't have access to the current paging schedule, you can always contact Health Sciences Center paging. Thank you.